Okay, so endomyocardial fibrosis. It is a commonest form of endemic restrictive cardiomyopathy of unknown etiology in the tropical and subtropical regions on 20 degrees of both sides of the equator. It is described as Davis disease when it was first coined by J.N.B. Davis while he was working in Uganda in Africa. The epidemiology, there are around 2,500 cases reported worldwide. Mozambique has the highest prevalence, but the thesis heart failure study from Africa published in 2011, only 1.3% of the patient had endomyocardial fibrosis. This is a population study published in NEJM, echocardiographic screening of 1,063 subjects from Mozambique. 20% was the prevalence. Of them, 56% were biventricular, 28% were right ventricular. And 10 to 19 years was the age of the patients. And what are the etiological factors in endomyocardial fibrosis? Most commonly cited etiological link is eosinophilia, because the study from Uganda has shown that 60% of the EMF had eosinophilia compared to 10% in controls. And we know that EMF resembles a late stage of low-flux endocarditis, which is associated with eosinophilia. And parasitic infections, prolonged drug-induced eosinophilia, eosinophilic leukemia, all can lead to endocardial fibrosis. But there are some points against the eosinophilia theory because serum and myocardial eosinophilia has not been consistently documented. In Kerala, India, where most of the EMF did not have eosinophilia at the time of diagnosis, and biopsies have not demonstrated eosinophilia in the tissue. Whether the eosinophilia only in the acute phase of the disease, we don't know. Infectious etiologies have been proposed, like toxoplasma, rheumatic fever, malaria, filariasis, helminthic parasites, but a consistent association with one organism has not been demonstrated. Immunologic anti-myosin antibodies have been demonstrated. Malnutrition, protein deficiency has been proposed. Toxic agents like tapioca or cassava or banana has been proposed, and genetic link also has been proposed. There are two interesting geochemical hypotheses proposed from Kerala, India, and the cerium magnesium theory. When the cerium levels are high and the magnesium levels are low, because cerium can induce myocardial fibrosis. And there is another interesting theory of geochemical hypothesis where in Kerala, the region where the EMF is predominant have huge deposits of monazite, which is a semi-radioactive mineral. Where there is an association related to that, it is not still clear. So coming to the summarizing the pathogenesis, basically whatever etiology from eosinophilia to infection to geochemical, all this lead to fibrosis and obliterative thickening of the endocardium of one or both ventricles. So this is the pathological specimen. You can see that the ventricular endocardial thickening and fibrosis all will lead to the adherence of the posterior leaflet of the atrioventricular valve to ventricle, leading to what is called a valve tethering. There can be thrombus, there can be valvular regurgitation. There are stages of EMF described, not definitely in all, but these are the three stages proposed. Phase 1 is the inflammatory phase, characterized by necrosis and intense inflammation of the endocardium, similar to low-flux. Thrombotic phase, 1 year after the initial presentation, non-specific thickening of the endocardium with a layer of thrombus replacing the inflammatory portion of the endocardium. Late phase is the fibrotic phase, which is the most commonly we see such type of cases now. Clinical features, the right ventricular endomyocardial fibrosis is a triad of elevated jugular venous pressure, ascites, hepatomegaly, and cyanosis and clubbing if there is a stretch open PFO. LV endomyocardial fibrosis, mild cardiomegaly, loud left ventricular third heart sound, short systolic murmur of mitral regurgitation, and severe pulmonary hypertension can be associated. This is the characteristic egg-on-stick appearance of the patient's large abdomen with ascites and relative absence of pedal edema. That is one characteristic feature. And ascites is a characteristic feature, especially in right ventricular endomyocardial fibrosis. Yeah, for almost 50% of the patients have it. it is related to a greater involvement of the right ventricle associated with the tricuspid regurgitation and associated with the worse prognosis. Why ascites predominates? High prevalence of hypoalbuminemia. Even if you treat the ascites may not resolve, even if the congestion is resolved, probably it is the fluid is exudate and with the predominance of lymphocytes. It's thought to be due to the peritoneal inflammation and reduced capacity to reabsorb the peritoneal fluid. ECG findings of RVEMF, two characteristic features, the right atrial abnormality and a QR pattern with a diminutive R wave in lead V1. That is shown in the pictures. The second is the left ventricular EMF of findings, left atrial abnormality, atrial fibrillation, STT abnormalities. So ST depression and T wave inversion similar to what you see in hypertrophic cardiomyopathy. Then when they develop PAH, there will be right ventricular hypertrophy and right axis deviation. But ventricular tachycardia and sudden death are not that common in endomyocardial fibrosis. I will show you some images. This is the X-ray of one of the patients. You can see that here there's a significant cardiomegaly, right atrial enlargement, and you can see the calcium anteriorly in the endocardium. You can see the whole RV endocardium is calcific. Another X-ray showing the LV endocardium thickened seen in a chest X-ray. This is the diagnostic criteria proposed by Mokumbi et al. Different criteria, major and minor. So when there is one major and two minor criteria, you diagnose it. Less than 8 the score, mild EMF, 8 to 15 moderate disease, and more than 15 severe disease. Some of the echocardiographic pictures you can see here. The LV endomyocardium, the endocardium is thickened. You can see the mitral regurgitation. You can see the thickened endocardium, and you can see the right ventricular EMF. You can see the right ventricular endocardium is significantly thickened and the cavity is obliterated. Here you can see the biventricular endomyocardial fibrosis. Cardiovascular magnetic resonance imaging is the definitive diagnostic tool, where you see apical obliteration of RV or LV, reduced volume, shrunken ventricle. Subendocardial LG or late gadolinium enhancement is classically seen. It is not restricted to any coronary territory, affecting mainly the apex of the involved ventricle. Outflow tracts are usually preserved. So it is you have to differentiate from apical HCM and apical thrombus and even non-compaction. Double V sign is characteristic, as you see in this picture, where the inner thickened endocardium, enhanced endomyocardium, overlying enhanced thrombus, and the outermost normal myocardium. These three will produce the characteristic double V sign. LVEMF, you can see the echocardiographic picture showing the thickened, in the senior run, you can see the thickened and obliterated left ventricular myocardium. Cardiac catheterization rarely done because intracavitary thrombi may cause a problem, but hemodynamic studies may show a restrictive pattern diastolic dip and plateau tracings. So this is an example of an RV, right ventricular endomyocardial fibrosis. You can see the whole the right ventricular cavity is obliterated. Only the inflow and outflow tracts are there. This is again showing another case of right ventricular endomyocardial fibrosis. This is an example of a left ventricular endomyocardial fibrosis. You can see there's a bald left ventricle, the trabeculations are absent. And here you can see the obliterated left ventricle with the calcium in the middle cavity. This is again a fluoroscopy showing the calcium, and this is the clenched fist appearance classically seen in the left ventricular endomyocardial fibrosis. What is the therapy? It is basically medical therapy, involves decongestion. Spironolactone we give in higher doses. We have even given up to 100 to 150 milligrams in some patients. Digoxin can be given to control the heart rate. Atrial fibrillation may be there. Rate control can be tried. Oral anticoagulation if there is thrombus, and abdominal paracentesis for ascites. Surgical treatment can be done. Endocardiectomy plus valve repair or replacement. Bidirectional Glenn, which we use for single ventricle repair, are also tried in right ventricular endomyocardial fibrosis, isolated right ventricular endomyocardial fibrosis, when there is no PAH or MR or any evidence of LVMF is a contraindication. Why surgical therapy is recommended? Because initial cases had a very high therapy on medical management, poor prognosis in the long term with medical treatment. 10-year survival after surgery was good, around 17-year survival was around 55%. And we know that hemodynamic derangement is due to restriction and AV valve incompetence, which can be corrected by the endocardiectomy and AV valve repair. And rarity of the myocardial involvement by fibrosis, that is another rationale for the surgery. And rarity of recurrence of the same fibrotic process after endocardic. Only around 6% of the patients had recurrence. So once it is done, you have a good chance of. This is a patient who had a mitral valve repair and surgery, but this patient had a recurrence. You can see the mitral valve ring. The Brazil series of 18 patients, the mean age was 31, 90, very high operative mortality is there, 19% operative mortality, and as 9 late deaths due to EMF-related issues. The actuarial survival in this series, 17 years, it is around 55%. Indian series, 89 patients, mean age was little lower, 25 years. Operative mortality is very high, 29%, but the late mortality is 12%. So if once they survive the surgery, the immediate postoperative period, the long-term outcome must be good. This is an example of a bidirectional Glenn and shunt done from our institute. There are other case reports also. What is the clinical course of endomyocardial fibrosis? This is one of the earliest series of 145 patients, 1975 to 1987. 1 year survival was 76%, 10-year survival was only 26%, very high mortality. So coming to the point where there is a reduction in the incidence, this is the data from Uganda showing that after 2012, there's a drastic decline in the number of cases of endomyocardial fibrosis. This is our data from our institute. You can see 1976 to 1990, we had 295 cases. Number of cases per year was 20. 91 to 2001, it came down to 10. Now we have around 3 to 5 cases per year. And the mean age, you can see from 25 to 33 to 50. And the number of patients below 20 years, from 38 to 15 to 6%. Last few years, we don't have any cases below 20 years. So the number of cases are coming down. The age profile is going higher and the prognosis is better. So change in profile of endomyocardial fibrosis over 4 decades. The age group from a disease predominantly in the young in their teens in the 1970s to a disease presenting the 4th to 6th decade of life presently. No cases the age group less than 10 years or 20 years in the past several years. Presentation in NVHA class 3 and 4 has decreased and prognosis has improved with a mortality of less than 10% over 3-year follow-up. And many of patients are referred for abnormal ECG or echocardiographic findings. And higher age diagnosis may be attributable to an absolute decrease in the incidence of the disease and patient presentation with the milder forms of EMF later in life. Why it is coming down, we don't know exactly, but improvement in the socioeconomic status, change in diet, less tapioca, cassava, and banana, improvement in diet, more protein consumption, the malnutrition part is taken care, diarrheal diseases, helmintic and parasitic infections are less, geochemical reduction in serum levels have been documented. So to conclude, ladies and gentlemen, endomyocardial fibrosis is one of the common restrictive cardiomyopathy in the tropics. Etiology is still unclear. The profile is changing as we have seen. Incidence is coming down and severity is getting less. Age presentation is shifted from the first to second decade in the 70s to 5th to 6th decade now. Prognosis is significantly better now. Surgical therapies improve survival, though perioperative mortality is significant. So thank you, and you are all welcome to Heart Failure Association meeting in Ahmedabad and in February. Thank you.